Good morning, everybody, and welcome. Thank you so much for joining us for our third and final webinar for our patient-based evidence series. Before we get started today, I'd like to acknowledge the traditional owners of the lands on which we all meet and pay my respects to elders past, present, and emerging. If you haven't joined us for our previous sessions, my name is Jessica Bean and I am Chairperson of Patient Voice Initiative. I'm also a patient living with cystic fibrosis and diabetes who is really passionate about ensuring that patient voices, our voices, and experiences are seen, heard, and represented in healthcare decision-making. I believe that this is particularly important as we see medicines coming to market that raise the bar in innovation and work in ways that mean that we don't only need to capture how they keep us alive, but importantly, the value and the impact of how they are enabling us to live. I've been really thrilled over the last few weeks to see these sessions go live. They've been something that has been part of the PBI vision since we released our report in 2018. And I can't thank enough the members of our steering committee at PBI who have been working really hard over the last few months to put them together as we took them from an in-person event to online events. A particular thank you to Anne Single and Simon Pfeiffer. Importantly, these sessions have brought together stakeholders from across the healthcare ecosystem to contribute and share their extensive knowledge and perspective. Increasing dialogue between, increasing dialogue and collaboration is at the heart of PBI, and enhancing opportunities for patients to have a voice in healthcare decision-making cannot be the job of any stakeholder, any one stakeholder. I think this series has really demonstrated that from the wonderful presentation that we had from Jo Watson of the PBAC and the input into these sessions from Sally Wortley of the CEEU, to the researchers and academics that we've heard from, and of course, the patient groups that have given us inspiring examples of what patient-based evidence can look like. Of course, these sessions would not be possible without our industry sponsors also, and they've made these sessions free, so cost isn't a barrier to increasing knowledge and building capacity. Thank you so much to our sponsors for your commitment to our work, and also for your enthusiasm and interest in this series, and the appetite that you have for the ongoing dialogue in this area. Before I hand over today's speakers to Dr. Stephen Holden and Dr. John Rule, just a couple of housekeeping points. We will definitely have time for questions at the end of the presentations today, which will be chaired by Anne Single, and you can pop them in the chat as we go. As you probably know, these sessions were designed for patients and patient groups, and taking these sessions online has meant that we can have open them to broader participation. However, if you are not from one of these groups, would kindly ask that you add your role or your company at the end of your question so we can prioritise those patient group questions. We've recorded all of the sessions from this series and they will be online very soon. We will not be providing the slide deck separately. If you would like to know as soon as those recordings are up, please don't forget to sign up to our mailing list and follow us on Facebook and LinkedIn. We're also currently working on some more work in this area that's going to be really exciting and engaging, I hope. So those platforms are the best place to stay up to date and make sure that you know when these become available also. So it's now my pleasure to introduce Dr. Stephen Holden, who is a researcher with experience in academic marketing and social research. In academia, he's conducted and published research in the areas of public health, social marketing, marketing research, and ethics. He's taught research methods, statistics, data analysis, marketing, and philosophy to diverse student groups. As a marketer and social researcher, he has conducted quantitative research for a wide range of clients in government, patient groups, medical devices, and pharmaceuticals. Thank you so much for joining us today Stephen.
You're welcome, Jessica. I will just put up my slides. Hang on for half a second. Share and bingo. All right. So if we've got this right, you should be all looking at qualitative equals open mind research. Somebody will tell me if you're not seeing that, I hope.
It's looking good. Thank you.
Thank you. All right. So welcome everybody. And I guess I take my task today as being one to try and introduce everybody to the idea of qualitative research. I've taught research for years, and it's a funny thing because when everybody thinks of research, they think of surveys and they get scared because it means statistics. I actually tell people we're all of us natural qualitative researchers. And maybe the best example of that is pictured here in the scene, the idea of traveling to another country. So, the key task of qualitative research is to understand the diversity of experience of other people. And so instantly we understand how this relates to patients who have diverse experiences individually with their own conditions and with their own dealing with that and so forth. So qualitative research, though, really requires, we're all native qualitative researchers, but it does require us to open our minds. And the reason for that, there's a default assumption in human kind of thinking. And that default assumption is that everybody else is just the same as me. Everybody, why don't you think like I do? Why don't you operate the way I do? You're doing what? I don't get that. And those kinds of problems that we face in the world, and I imagine many patient groups suffer this when they're talking to people, it's like, you don't understand what it's like to live in my skin, in my shoes. We're dealing with the fact that everybody sees the world subjectively through our own eyes. And even though we're seeing other, we're constantly seeing it through our own experience. So there's a couple of problems about this default assumption of seeing the world as I see it. The first one is that it's harmful. It leads us to misunderstand and, even worse, to judge and act according to some assumption, which is a nice word, or prejudice, which is not a nice word, but they're roughly the same things. I make a presumption about how someone is based on my own experience. The second problem with this default assumption, everybody else is like me, is that it's frustrating for others. Others have to remind us constantly of their lived experience. That is, what is normal for them. And the third one, and importantly for marketers, whether they're selling medications, treatments, devices, doesn't really matter, is that it's wasteful. When we presume that everybody else is like us, if the marketer presumes that others are like they are, they're making a mistake and they're leading to misdirected marketing. All right, so let's just sort of try and flesh this out a little bit more. So in qualitative research, in my way of thinking, other people are foreign countries. So take the example of, if we were in a room where I could see you all, I'd ask you to raise your hands. How many of you have seen the Eiffel Tower? How many of you have seen the Statue of Liberty? I mean, in the flesh, so to speak. And if you've seen those things, do you think that you know Paris? Do you think you know New York? Have you seen the Opera House? Do you know Sydney? And of course, there's a massive difference between visiting these places and ticking off, yes, I've seen the Eiffel Tower, I've seen the Arc de Triomphe, I've seen the Statue of Liberty, I've eaten a bagel down on the Lower East, etc., etc. It's not the same as living there. And perhaps that's most clearly when we think about the distinction between people that have visited Australia, who have seen quite often way more than we Australians, versus our lived experience of being an Australian. And I use the term Australian very broadly. We had an acknowledgement of the original custodians at the beginning, and their experience is different as well. So what I'm talking about here, not only are other people foreign countries in the sense they come from foreign countries, but they're foreign countries in the sense of their beliefs. We often, in fact, think of religion, Christianity, Islam, and atheism perhaps as foreign countries. One of the most famous distinctions made between males and females was John Gray's men are from Mars and women are from Venus. They're not just different countries, they're different planets. And of course, it is very tricky, I think, for men and women to understand the lived experience of the other. That's what qualitative research tries to address. And so for today, of course, we've got all of these other conditions, if you like: autoimmune disease, cancer, obesity, nutrition, autism, dementia, which were just some of the areas I saw covered by some of the participants. These are all foreign countries. How do we learn about these? I just want to think about one or two of these for a moment. Autism. At the moment, I'm not sure if it's on right now, but Tim Sharp has become famous as a boy. He started drawing cartoons about the Laserbeak Man. And there's been some interesting programs about him. How do we learn what it's like for someone that has or is identified as autistic? The Rosie Project, written by Graham Simpson, is a fascinating another picture of someone with autism, a completely different story. Dementia, again, fascinating condition, tragic, and the stories of people like Sandra Bem, a psychiatrist who in fact chose euthanasia to get out of it in the United States, and Oliver Sacks, who also wrote about it, are all interesting insights into this. So this is, and Oliver Sacks is a good example of a person who I think has done a lot of qualitative research. His whole book, Awakenings, is in fact an argument that medicine needs to move away from quantitative and more to qualitative. Qualitative then is really provided to us to better understand what is normal. Now I hate the word new normal at the moment, and we talk about, but I'm going to give you a new normal. When we talk about normal in a quantitative sense, we mean the duration of a disease or the prevalence of a condition. I want to talk about qualitative normal, which is how much variation is there in normal. I hear people describe people on the spectrum, and I like to remind them we're all on the spectrum. What you mean when you say that is you're focusing on one particular end of the spectrum. Not only that, but there are multiple spectra. And in fact, we all are rare on some spectrum, and we all have special needs on one spectrum or more. All right, so let's get down to some of the nitty-gritty about qualitative research. I mean, what are we trying to do with qualitative research? Fundamentally, we're trying to answer the question, why? Here's a quote from Douglas Adams, one of my favorite authors. When you hear the word why, you know you've got one of the biggest unanswerables on your hands, such as, why are we born? And why do we die? And why do we spend so much of the intervening time receiving junk and spam email? Why indeed? So the question that is asked in qualitative research is very often why. In quantitative research, it's very often how much, how many, what proportion, how long. So the difference between the two research projects is often started by the research question itself. Now we'll look at the design of qualitative research. And frankly, the design probably doesn't matter so much. What we're trying to do in design is doing something to get the other that we want to understand to talk. I mean, the first methods, and this reflects that qualitative research came out of anthropology, is to observe people, participant observation, to live with them, ethnography. So if I can get into their space and spend some time with them, then I understand. And again, think about this in the case of medical conditions, to have someone walk alongside you if you have, I don't know, IBS or rheumatism or some condition, particularly a chronic condition, it gets this other person to go, wow, so this is a different lived experience for the other person. Another one is patient discussions or in-depth interviews, a little bit as we see pictured there. Just get people to talk. Case studies. Again, I allude again to Oliver Sacks's book. The film was based on the book called Awakenings. It's actually a series of case studies of each patient that was suffering from Parkinsonian syndrome and their treatment with L-dopamine, and how much they needed to be treated with to come out, how long they lasted, and how long before they fell back into their sleep. So, these are the design sort of questions. And finally, focus groups, which are well known. Personally, I think they're a little overused. We get a lot more from people by just listening to individuals speak their experience. We don't enjoy somebody sharing their holiday trip to Rome while I'm trying to say what my holiday trip to Rome was like. So in a sense, I think these are a little overused, but that's, I guess, choose the method that's going to best encourage people to speak. The next point is, what should the questionnaire, if you like, look like? What's the instrument? Well, the instrument's called a discussion guide. And mostly, much like the design, it's anything to get the other person to talk. So sometimes I've seen people that have naturally been quite good at describing their experience. At the moment on the internet, if you look up the incidental economist, there is a medico, I'm sorry, I can't remember what kind of medico he is. His name is Bill Gardner, and he's been diagnosed with cancer, and he's telling his story. And it's fascinating for people that have a bit of a medical background, as he does. And he talks a lot about his experiences. He's confronted by questions that he's never thought about. He's now not in the seat of the doctor or the practitioner. He's now in the seat of the patient. Another person that I encourage reading is Ranjana Srivastava, who's on The Conversation. She's an oncologist in Melbourne, I think, and writes beautifully about patient experience. Again, she's a natural qualitative researcher, in my opinion. And if you want to know about cancer, there's a great place to go and learn about what it's like for people. So some of the techniques we can use here to try, if we have to prompt people to speak, we might use association and completion. So for instance, I say to them something like, and I know that John's about to talk and identifies as HIV. What does HIV mean to you? What do you think it's like? What's it mean to other people? What's that bring up for you? Another technique we use is stereotyping. Bill Gardner sort of gave me this idea. I've never had cancer, but what is chemo? What's radiation? What's surgery? What do those three different kinds of approaches mean? Maybe I can personify them. What kind of person is chemo? An aggressive, nasty, brutal person. Radiation, also brutal, but very pinpointed. Surgery, wow, that's like, a hatchet man. We can also use indirect questioning. So remember I said earlier on, one of the things about qualitative research is we're trying to overcome that presumption that others think as we do. Ironically, we can use this technique, and it has been used. How do we find out how much a person drinks? They don't like to tell us. But if you ask them, how much do your neighbors drink? Thinking of the nearest 10 neighbors you have to you physically, how much do they drink? Most of us don't know. We project how much we drink into our answer. And the final one here is meaning making. Meaning making is the way that people tell stories. Show them a picture of a hospital and ask them what it means. By the way, the picture here shows two hands handcuffed together. It's famous because it was actually dismissed in the UK as racist. Is this picture racist? That's one story. Here's a couple of stories. It's a white prisoner and a black prisoner handcuffed together. It's a white cop handcuffed to a black prisoner. It's a black cop handcuffed to a white prisoner, or it's two guys, consenting adults who are having fun. There are lots of stories here we can tell. When we get people to tell the story, it projects onto what's happening. How do we sample? Our sampling is not representative in the quantitative sense. It's representative in the qualitative sense. We're trying to capture all the variation. So there is no fixed sample size. We continue until nothing new is emerging. We're looking for insights, not averages. We're like a connoisseur who's tasting wine. I think I smell some licorice and maybe some mint. as opposed to, say, a value buyer that says, I need the maximum alcohol for the dollars spent. So qual and quant are not the same thing. And I'm mindful that I'm just at the end of my time. So if the organisers will just give me a moment, I'll take another minute or two. Qualitative and quantitative are not the same thing. So look at these two research questions. Which product or service would patients prefer? This is a polling question. What proportion of people prefer treatment A versus treatment B? The second question, what are the strengths and weaknesses of the product and service versus others, is a qualitative question. I need to talk to people. What did you like about this treatment? What don't you like about this treatment? So that's the sense that the research question drives the method. So qualitative is a story, but a very important story. Many of you I know have come to be in the kinds of organizations you are, either through a personal story or the story of someone that's near and dear to you. So we know that qualitative research really works and it is informative. Quantitative is the other version. It's statistics and correlations and numbers. So in summary, the research questions for qualitative is why? What are the reasons why people do what they do, choose the drugs they do, choose the paths they take? The design, observation, ethnography, depth interviews and focus groups. The instrument, a discussion guide, a set of questions that will encourage someone to speak, and projective techniques, just clever little probes, if you like, to get them to say something that they might not reveal otherwise. And finally, the sampling, not representative in the quantitative sense, but purposive, designed to capture the range of responses, and exhaustive. I keep going until I stop learning anything new. And there you go. I'm done. Sorry, 17 minutes. Thank you.
Thank you so much, Stephen. I'm glad that you were keeping track of the time, because I was so absorbed in your presentation that I certainly wasn't. I'm sure that there'll be plenty of questions for you at the end, because that was just really fantastic. Thank you so much. Next up, we have another fantastic speaker. John Rule is the Senior Manager of Research at the National Association of People with HIV Australia. He's a person living with HIV and is dedicated to seeing just and fair outcomes for all people living with HIV in Australia and elsewhere. He has conducted qualitative research studies in Papua New Guinea, and working in the Asia Pacific region, he has also been involved with academic research projects focused on human resources for health. John holds a Conjoint Association lecturer position, School of Public Health, Community Medicine, and the Faculty of University of New South Wales. John and the HIV community have made really huge contributions to the patient advocacy space over many years, and have really led the way, I think, for other groups. So it's a real honour to have John speaking with us today.
Thanks, Jessica. I'll just share my screen. Is that coming up?
Yes, it's coming up. Thank you.
Thanks for the introduction, Jessica, and thanks, Stephen, for the really great opening up about qualitative research and how it might be used. I guess we're exploring the proposition that qualitative research can add to, enhance, and be centrally positioned in representing patient experiences. Yes, what you said earlier was important, Jessica, in the sense people living with HIV, we've had almost 30 years or more of being in this space. So in a way, some of the approaches we've developed might appear sophisticated, really, but it's really been a big effort to get to that point. For example, here, a study called HIV Futures 9 has been going on for over 20 years. It happens every 2 or 3 years, run by the La Trobe University, the Australian Research Centre for Sex Health and Society, we collaborate with that group, and what that does is every couple of years we get an update on the quality of life for people living with HIV. That study operates in such a way that quantitative data can also be drawn out, but also qualitative data. And I've just put a couple of dot points there from the last HIV Futures 9 that 56% had reported at least one experience of HIV-related stigma, and that 38% reported that they had been treated differently by their healthcare workers due to HIV in the past 12 months. So there's a little first example of the problems, perhaps, of engaging groups in qualitative research where stigma exists. And I guess that stigma is something that is not only experienced by people living with HIV, but is experienced by many patient groups. We've had a chance to reflect on what have been the barriers and the facilitators for people living with HIV being involved in research and qualitative research. Talking about stigma, of course, we all have health-related challenges. That's why we are patients, and as consumers, sometimes it's you have to manage your own life as well as being engaged in these sets of activities. Got their lack of capacity to engage in research. I'm not really putting that there as a deficit, but we're not all born researchers, and because we maybe contract a disease or acquire a disease or develop a disease, it doesn't mean we automatically achieve this capacity and an automatic understanding of research. So that implies to me that the kinds of things that are happening, for example, today in the webinar, are building capacity of people to engage in research and to develop it and to push it forward, so that when the the other is heard, which was the point that Stephen was making. So some of the things that facilitate the meaningful involvement of people, I'll just pick out a couple there. Training and mentoring, which is the other side of that lack of capacity that I was talking about. People have to be financially compensated if they're involved in research. In the introduction there, I said I worked in Papua New Guinea, and that's an important part of getting people engaged in research. Trust building and understanding the health needs of the group facilitates that. We were lucky enough last year to have a day where the different state-based groups gathered and we shared our experiences from Queensland, Victoria, New South Wales, Western Australia. And we invited researchers who we work with into that space. So really it was a coming together of what assists good qualitative community-based research. And we were able to identify some principles. It's based on mutual respect and trust. The partners really need to commit to a long-term and sustainable relationships. It has to have the methodological rigour and sound ethical practices, and Stephen alluded to those. The kind of projects that work build on existing strengths of the community, and we always hope to have flexibility and an eye to the longer term vision. Just as an example, there's an emergent community need. We are living longer with HIV, but with that, the experience of living longer also brings with it experience of living longer with many comorbid conditions that people are experiencing, multimorbid conditions, renal, osteoporosis, cardiovascular, vulnerability to cancers. There's a whole lot of things that are now impacting upon the ageing population. So we realised that within our organisation quite a number of years ago, and we thought we had to get the ball rolling really. So we collated some material and published a report. But at the same time, we learned that other researchers had begun to focus on this. And I'm just using a couple of slides there from Lisa Fitzgerald and Alison Mutch, who work in Queensland, were looking at the experience of people in Queensland who are isolated and living longer with HIV and suffering many of these comorbid conditions. Lisa and Alison contributed to our discussion and talked about the, they called it the social research dance, or maybe it's a qualitative research dance here. But part of that dance is about funding and getting the right connection in terms of researchers who might be involved in doing this work and collaborating with them. So at the end of their research, or it's actually ongoing, Alison and Lisa were able to say, yes, we were co-constructing knowledges, and it was a collaborative process with people in Queensland. It led to peer-reviewed research papers. It gave, and then Alison and Lisa were thinking, and the other people from Queensland Positive people were thinking how to move this into a national conversation, because ultimately, if there's to be a response to this, then the area of aged care is a national responsibility. So we have to develop these stories, bring them forward, and then put that onto a national research agenda. We have a national HIV strategy. It doesn't necessarily have dollars attached to it, how that strategy is to be implemented, but the value of getting research prepared and bringing it onto the national arena can't be underestimated. Some other ways in which we've worked, we've been involved in community advisory boards. But I think the co-investigator model is very interesting, and I really enjoyed the webinar last week on patient-reported outcomes and measures. In the HIV area, we've been able to develop a scale assessing the quality of life of people living with HIV. But an important part of doing that work was that the researchers joined with people living with HIV, ultimately becoming co-authors on a publication. And I think that's a really powerful way, because people then begin to own the outcomes of the research. And in the case of the positive quality of life measure, we now use it amongst our organisations to see whether they're getting the service they expect, and to measure whether their quality of life has improved from the first point of contact. We also are trying to have the positive quality of life scale used by GPs, although that is not a straightforward matter. So we're also seeing that nurses, nurse practitioners, social workers, etc., might be able to take the information from a self-reported quality of life scale, and with the patient or consumer, take that to the medical practitioners. I realise that there's a lot of different research approaches: traditional research, community-placed research, community-based participatory research, community-led research. I guess the point of putting this slide up is to get across that we have to somehow find our point on that continuum, but also the point of the slide is to say that we really see value in being involved in the process of the research design. Stephen talked about it again, but we need to be involved in the outputs and outcomes, including writing up the analysis. I just mentioned that this is a bit of a conundrum, and I'll finish in 2 slides. The HIV research in Australia is a very big picture, or a significant picture. Within that, we have biomedical research. Within that, we have social science research and a lot of behavioural research. And the community-based, qualitative, participatory research is really only a small circle within that. We'd like to see that extended. We talk about a research justice approach. So As the HIV epidemic has unfolded, the needs of women, the needs of people from Aboriginal and Torres Strait Islander background, and the needs of people from culturally and linguistically diverse communities are often not part of the research picture. So we're talking about a research justice approach to include everybody within the population. My last slide there just centres people living with HIV, or you could put any disease or consumer and groups. What we contribute is lived experience. We can say what's relevant. We can say what's not relevant. The other thing is that our bodies and our lives and our samples are what we contribute, and that also needs to be really valued. So qualitative research, we need more of it in our area, and I hope that the slide set I've provided you with gives a few clues that your group or organisation might be able to take up. Thank you.
Thank you, John. That was another fascinating presentation, and so useful for us to really hear from the depth of experience in your community. And so I think I've got the first question is actually going to be directed to you, but actually, Stephen, I'm sure you'll have insights afterwards. So if you want to put on your camera as well, I've got questions for you as well. So the first question, John, was, patient groups, you know, they often begin because someone has been personally impacted or affected by a diagnosis for themselves or for a loved one. And then there is an awful lot to learn in this environment. You know, you have to have your charitable organisation, and you have to work out your tax status and who's who, and even try and navigate the health system. So how can you begin to move from someone who can see glaring omissions and needs that need to be filled to someone who can actually get in and talk to researchers and think about what needs to happen in that space? It's a big question.
It's a big question, Anne, but to have a go at answering the question, I think the building of relationships and collaborations and partnerships is the only way to go. And if I can give a practical example from our area, the HIV medications that were available many years ago had very bad side effects. People suffered conditions called lipodystrophy, lipoatrophy. It's facial wasting and changes to the body fat metabolism. Well, first of all, when this started, doctors were going, oh, no, you're just getting older and you're getting a tummy. Or, you know, there was a little bit of resistance to people, to what people living with HIV were saying was happening to their bodies. Now, the only way that a response to that can start is if that person who's directly affected begins talking with other people about that. And then building up the picture. And as you say, it requires building structures, and I think building communities or connections so that there's an element of trust when it comes to prioritising what the patient group needs are. We have people who are newly diagnosed, we have people who've been living long term with HIV. Their needs aren't the same, and somehow amongst the population group have to make some prioritising of needs, and I think that requires a lot of trust because some needs have to be let go of. My needs might not be the needs of everybody else. So that's an attempt to answer.
Yeah, no, that's a very helpful answer, and it made me think, Stephen, you know, in your presentation, you conveyed qualitative research in such an accessible way that we could put into our daily lives. But often when we're not familiar with the research environment, I think we think, well, how would we come and talk to you? And I just wonder if you can give any ideas there about how people can begin this process.
Sure, and I think it also touches on Suzanne's question in the chat. How do we persuade decision makers who value quantitative hard research, as she said, that there's an equal value in qualitative research? Well, Suzanne, first of all, don't try to convince them it's equal, convince them it's actually more important. The way I think of this is, how can we possibly measure something until we know what we're talking about. Are we agreeing on the concept? And the medical world gives us lots of examples of this. I sort of gave the example of autism, which now has become a spectrum, which I think, by the way, is useful at some level, but it does annoy me that we talk about someone being on the spectrum as if the rest of us are not. We're all on the spectrum. And so inviting people to realize averages they capture very few people. And in order to understand truly what's going on, we can't look at a mean, we have to look at the variation. And we have to do that before we measure it. I guess that's what I would say. And how do you deal with decision makers? There's probably nothing better than going to a personal story. You know, if you know the decision maker and they have a personal story, their partner, a parent, a child, and they've gone through some story, it doesn't even matter if it's medically related, that's their experience of the education system, of medicine, of hospitals, etc. When people use their personal experience, they're using qualitative research. The invitation here is now get into someone else's experience. How are you going to get that unless we talk to them? There you go. Thanks,
Steve. And John, did you want to comment to that question as well?
Yes, to add to that, I see Pia has asked this question about how to find the right words to express what's going on. Last week, Jessica's introduction to the webinar struck me as an incredibly powerful description of problems with drugs, etc. And I was thinking, how do you capture those words and put them into a research narrative? I think that's a trick. But that question there that Pia has asked about how we help others perhaps to find the words. Again, I don't have a straightforward answer, but recently we've spent a lot of time on the concept of health literacy, and we've been pairing people up to help another person develop their health literacy. And I think we're playing with a similar concept in terms of our engagement in research. We need to develop a research literacy ourselves, and we do have to learn about how this thing called science operates, and the role of qualitative research in sometimes puncturing what science might assume, but also adding to science, which is what I think you were saying, Stephen. It's not one or the other. It's actually that there's great potential for qualitative research to show the answers and to add to what is known in the area that is measurable.
Stephen, I was interested in your discussion where you turned qualities and illnesses into people and metaphors, and how that enables us to retain the idea beyond a number on a pain scale, or the expression of having fatigue, which I feel is a valid thing to express, but somehow almost gets glossed over when people are talking about patient experience. Do you want to say a bit more about that? Because that was fascinating.
Yeah, and I mean, I think the notion, for instance, in health and in medicine of measuring pain is a classic example. You know, of course, we're all asked on a 0 to 10 scale, how much pain are you experiencing right now? It's weird because in that scale, medicine acknowledges that pain is purely subjective. And all they ask is on the scale. I mean, some people can tolerate quite high levels of pain on that scale and go, yeah, but I'm okay. You know, other people can't tolerate very much at all. And to think, when we think of, this is relating to what John was talking about, it's the problem of words. We think when we're using the same word, pain, we're all talking about the same thing. No, we're not. It's got multiple dimensions, and we need to understand all those dimensions. I've sometimes heard people say that qualitative sort of, you know, when we're quantitative gives black and white answers, black or white answers and qualitative gives grey. I actually go, no, it doesn't. It gives black and white answers. There are both. Those are all lived experiences. And again, this relates to Pia's point too about the words. How do we find those? Where do they come from? By inviting that person to speak. And the more they get to speak, the more they begin to articulate their experience, which when I heard that being addressed, it struck me the answer to that is time. Give the person time to talk. Yeah, I guess that's how I see that.
And to pick up on that, so when a patient group is putting in qualitative experience, it doesn't have to have everyone agreeing, does it? You can have different stories which conflict with each other, and that's the richness of it, isn't it?
I think precisely. And again, you're alluding to one particular technique, namely case studies. Again, there's an irony here. I think it's almost our lay view of health and medicine focuses us on evidence-based medicine. But in actual fact, when people practice medicine, doctors spend much of their time working on cases as they go through university. And cases are qualitative. This particular person has this particular condition, experiences it this particular way, has responded to the drug in this particular way or this treatment. And that might not tell us very much about what's going to work for the next person. So yeah, I think how to report it, it's not about trying to capture everything, but telling a couple of really good stories and very different ones, not the same ones, to actually capture the range of experience of people is very important.
And there's another question here on the chat, which is really interesting. I'd be interested in your thoughts, and an interesting one for us here at the initiative. Chicken or egg question. In order to meet needs of our community, qualitative research is needed. How can we start this process with no funding? And can we produce a document led by patient volunteers?
Yeah. I saw that, and if I can contribute, it is such an important question. And I have thought from my own experience that there's always going to be someone in the research field, if you like, whether they're involved in a university or other research groups, who I think might be interested in what we are experiencing. They want to research us. in a way, people living with HIV say we're one of the most researched populations. I mean, I understand why that has occurred, because it's a notifiable public health area, a notifiable disease in public health. But I'm just talking a bit about finding a person somewhere who will be interested in what the experience is that we're having. And if I can just share that in the area of that ageing that I was talking about, it wasn't a matter of going to some of our traditional research links, if you like, or the collaborators that we've always had, but it meant broadening out from the public health researchers, from the other researchers who have been epidemiologists and so forth who are interested in HIV. We then had to find people who were interested in the ageing process, and researchers who were interested in, they were researching ageing, but they hadn't really made this connection that HIV and ageing could be something to look at. So I don't know whether I haven't given an answer to the chicken and the egg, but I've just talked about a strategy that I personally use, and I think it's worth sifting through who is out there, who is doing research, and how might that be kind of brought across to your group or your interest.
Thanks, John. And Stephen, I hate to say this, but do we always have to come with money to researchers, or are there other things that happen? And I ask this because sometimes I get contacted by people saying, do you know of anything that's a good PhD project? Yeah, there's a lot out there. And so I sometimes worry whether we actually manage to tally and make this barrier between people with lots of questions and people wanting to do research and link them somehow.
Sure. So a couple of quick responses. First of all, do we need money to do research, and particularly qualitative research? My short answer to that is no. My longer answer to it is, which of course is, the no is to pique your interest. The longer answer is, well, then how do we do it? One of the suggestions you've made is a very straightforward one, to approach academia classes. In years of teaching, I've often encouraged people to come to me and using undergraduates or postgraduate students, have them conduct as a part of a course, a qualitative project. I really encourage people to do that. The second approach, and it relates to, I think, Pia's, sorry, it's not Pia, Ms. Bidd's question about the chicken and egg, is ask volunteers, ask people, particularly with a condition, to write their story. Once you've written the story, you have qualitative research. It probably needs a good editor, because when we get invited to tell our story, sometimes we use too many words and that doesn't fit in the report. So a good editor can bring it back to something that gives a picture, but also really gives us a sense of that person's lived experience, but also enables us to realize there are a range of responses and so on. So again, no, you don't need a big budget. You do need resources, you need time. You can borrow them from universities. Any class that's teaching research methods will often love to have somebody to do the research for them. So approach your nearest friendly professor, or ask the people to write their own stories.
Thanks, Stephen. John, did you want to say something there, sorry?
Yeah, if I could just add to that. So we can start, we can initiate things, we can bring others into working with us. I noticed in the chat, someone said yes, yes about the concept of the meaningful involvement of people with any disease in whatever the research area is. So I guess there's been some learning along the way that sometimes we've been invited in, and what looks like a bit of meaningful engagement sometimes can become tokenistic, and I think that's something to be conscious of as a principle, really. You know, that if people are to be engaged, then or if they're to collaborate with people, then there are a set of ethics around that, and I think being nothing worse than having your story taken and used in another way. That's what I wanted to add, Anne. Just that.
Thanks, John. It's very helpful, and I'm going to try and fit in 2 questions before, there's another coming in. So Janelle has asked, do you need to be able to get some kind of quantitative research to back up the qualitative research to kind of rule out sampling error? For example, if you get 2 people sharing terrible stories, whereas the majority have not had that experience, what weight should be given to those experiences, especially if you're trying to make a case to politicians or committees making decisions? I worry that this is why qualitative research is harder for decision makers. And I'm just going to be cheeky and squeeze this other pre-session question that came in, which is really how we use qualitative data relating to patient experiences the most effectively in PBAC and MSAC submissions, and about that weight. Now, I know neither of you are from PBAC or MSAC, but any insights you can give us into those substantial questions. Stephen, do you want to talk to that relationship between quantitative and qualitative first, and then I'll go across to John?
Sure, and I'm mindful of time, so I'll try to keep it short. Qualitative is often done before quantitative because it defines what we want to measure. However, qualitative can often be done after quantitative to kind of understand more depth behind the numbers. The point that was it Janelle that has posed that 2 people sharing terrible stories. Look, I'm a cynic here. If you want to convince the decision makers, give the terrible stories. That's the value of qualitative research. let them pull out the fact that 90% of the patients don't suffer this. It is cherry picking, and it is the reason that qualitative research is sometimes dismissed as non-scientific. But it serves a political purpose. It serves a research purpose. I think it's justified. If you're using it to communicate, sure, pick your best stories. I would again repeat what we said earlier on. I wouldn't try to have 3 stories saying the same thing. I would try 3 stories that sort of like the 3 bears, you know, good, bad, and neutral, or something like that. You know, so anyway, there you go. There's a thought.
Yeah, I'll try to respond very quickly, Anne. The webinar started off with Joe Watson giving a fantastic presentation on the health technology assessments and how to get the patient voice into that process. I think the question about engaging in PBAC, MSAC submissions, etc., is what is relevant here. My feeling is that having the qualitative data already generated so that it can be picked up by those who are making the submissions to the various government structures is being prepared. I guess that's what I'm trying to get across, that being prepared with qualitative data that can then be inserted into submissions and used by others who might be proposing something in this area, I think is how I see the way to go.
Thank you, John. I'm going to try and wrap up there. I can see another question though that's just come in that I wanted to address, which is we're interested in collecting our patient information experiences, but issues have been raised are privacy and data storage. Now, this has come up at earlier sessions, and Patient Voice Initiative was really keen to find a good example from a patient group that we could share for other people to model a policy on. And yet we've struggled to get a hold of that. John, you don't have one sitting in your top drawer that we could share? I'll put you on the spot. Or what's your advice there?
I think in the early years, the way it was recorded was the first 2 letters of a surname and part of a postcode. I actually can't remember how it was done officially with the Department of Health, but some very simple way of identifying the data is possible.
Stephen, would you give any tips there?
Sorry, about I was responding to Natalie. So
I could see you. No, thank you for keeping the chat going. I really appreciate the way the 2 of you have done that. Any advice about putting together a bit of privacy and data storage policy when you're a patient group, and how you should manage that, or place to look? Or
yeah, it's a complicated area nowadays. I do invite people or encourage people to think very carefully about privacy and what needs to be kept private. So when I read that question, I thought in respect to qualitative research, it's actually quite easy to disguise a story. In terms of data, yeah, I think that's a massive, to be honest, I think it's a massive topic, and it deserves attention all on its own, because on one hand, I think people have got what I call a privacy boogeyman. They're scared about revealing information to what I'd call genuinely useful situations. And on the other hand, they reveal way too much information in situations where they ought to be scared. So, you know, a classic example is they won't accept my health, but they'll happily reveal so much about themselves on Facebook that pretty much anybody can find out. Again, it's just sort of way too big to do in this. But yeah.
No, I absolutely agree. So I'm sorry, that is going to be an item for Patient Voice Initiative to follow up with and to keep looking at, because we know that that's a big issue for people, and probably completely wrong to put you on the spot there, Stephen, with that one. Okay. Now, there's more questions, and I'm sorry we've run out of time, but I hope we'll be able to go through them and work out some responses and keep that conversation going. I'm just sharing a screen to remind me to to wrap up now. And first of all, I want to thank Stephen and John for a really engaging session today, and a really reflective one, which I actually think turned out to be perfectly timed in this 3-part series. And I want to remind people that we will be sharing all this on YouTube. We're a little bit behind with putting subtitles on, but we will contact you through your registration email to let you know when the 3 YouTubes are up. And you can also subscribe at our website, and that will mean whenever we publish, you receive information about what's available. You can also follow us on Facebook and LinkedIn. Can I also thank Sally Wortley from the Consumer Evidence and Engagement Unit in the Department of Health. Sally oversees the Consumer Evidence and Engagement in all of the health technology assessment units, so MSAC and PBAC as well as PLAC, and has really been invaluable in shaping these webinars and working with us collaboratively on our workshops and training, as well as Simon Pfeiffer from CaPPRe, who's also on our steering committee, who very generously gives a lot of time to talking through these issues and helping us find speakers and so forth. And can I thank some of our earlier speakers, Steve Roach and Nella Coombs from Myeloma Australia, Rachel Morton from the University of Sydney, and Simone Layden from Neuroendocrine Cancer Australia. Thank you to the audiences. Some of you have been here each week, and the questions have been fantastic and the discussion has been fantastic. And finally, can I thank Jessica Bean, our chair, for guiding us through. We're very lucky to have a leading patient voice initiative and really informing everything that we do. And finally, I'm particularly indebted to Ray Pastors, who is our IT support. Anyone who knows me knows that it's a miracle my computer gets turned on. So I'm very indebted to Ray for keeping these things humming along smoothly. So thank you to everyone for joining us again today, and we look forward to seeing you in person again one day.
Thank you, everybody.